screening, which I know someone in California here said they've been doing. And what this is, recommended that diabetics have an annual eye exam so they can check the retina. And Dr. Shara has told me the reason for that is so that clinicians can know how bad, how well controlled diabetes is. Because when you look at the retina, it's like looking inside the person's body. It's knowing their kidney status, their heart. I mean, it's looking actually at the cardiovascular function and the impact diabetes has on the body, as well as if the person needs treatment, because we know that diabetic retinopathy is asymptomatic, no symptoms in its earliest stages, and if screened early, can preserve the person's vision if treated. So anyway, this little machine, you can see it. It's like the one you go to the eye doctor with. You know, you set your chin on, and you put the air pump in, or they look in your eye. And on the other end is a camera where they can actually take a photo of the retina, and that's what you're seeing. That red thing is actually the retina with the optic nerve and the vessels going into it. And that's what gets emailed off to an eye specialist, who then can determine if there's retinopathy changes. So what does the literature say about this? It says, systematic review published in 2010 in Diabetes Medicine summarized the following statistically significant evidence. Researchers in Canada and Great Britain have demonstrated likewise. It's cost effective, it's preserved sight, it has increased access for patients in remote and rural areas, it's decreased time to treatment, and it's decreased time for patient time and distance travel. And here's what we did. We actually got equipment from a grant from our Rural Health Network back in 2008. Dr. Shara was our provider who read over 400 images for us. And these were mostly farm workers we did. We didn't just do diabetics. We basically screened everybody that came in because we wanted to get used to seeing the equipment and tested our systems out. And the majority of the patients were uninsured. We did find pathology in about 5% of the patients, but interestingly enough, we really didn't find too much in retinopathy. 10 minutes. But we did find a lot of glaucoma changes. You can pick up other pathology on this, as well as cataracts. And we also found people that needed eye exams. So off they went, and we got people into treatment, and they completed their annual eye exam. And I think this is our last application, which is teledentistry, which is a really exciting area for us. And the clinical applications for this is that you can actually do screening. For instance, our children that go to daycare centers, the migrant daycare centers, have to have a screening within 30 days of their enrollment. Also urgent care consults if there's a toothache, or again, specialty care if those children need to see a pediatric dentist. So the literature says about this is that there's actually very few random control trials. Much of the studies have been done on small sample sizes to determine feasibility and reliability. But it is our friends at the University of Rochester, where Dr. Karp works, who are leading the way in the research. And actually, I think this is really pioneer work that we're actually doing with this. And what the literature said is reliable. There's no difference with the face-to-face visual exam when compared to intraoral digital photos. There's improved access. It's a feasible way for screening, diagnosis, and treatment, and it is cost effective. So I just want to tell you a story about the screening that we've actually done over the past year. We went out to our daycares and we screened 33 children using that little camera, sending the pictures off to our dentist, and found out about 27% had pathology. And we helped them all access treatment. That was our first activity with the cameras. And then we started working with Eastman. And we actually did, at the time I made this presentation, and I've got 20 more referrals coming when I get home, we did 9 referrals on different areas of those counties, in our area. Again, mean time to consult, 13 days. Dr. Karp will tell you it's like 9 months sometimes for children to get an appointment in those tertiary centers, just because they serve so many. But telemedicine helped shorten that time. Again, time to treatment was 9.9 days. I think that skewed a little bit with our first session that we did, but still, it's very remarkable. I think probably it's been no more than 2 to 3 months for the children to get treatment now. Again, very high patient satisfaction survey scores, telepresenter. I asked the telepresenter at the time, who's usually a hygienist or Tony, our dentist, to actually fill out a survey, and the specialist as well. So again, all above average scores. And I'll tell you about this little tale from Seneca County, which is one of our poorer counties in New York State. The children living in poverty there is higher than New York State average, with incredibly high caries or decay rates. 143 out of 10,000, which it's the normal rate, or not the normal rate, but the rate throughout New York State is 87, so it's almost double. And again, you can see Seneca County is over by Port Byron on the right end of your screen, so a good 60, 70 miles from Rochester, maybe. And we coordinated with our Agribusiness Child Development Center, our dental hygienist. We send our hygienists out to we send our hygienists and dentists out to our daycare centers to actually do care, so they're very familiar with the kids. And then, of course, Dr. Karp. And this is the equipment we use, similar to what we used here, the portable unit, and there's our dental camera. And our hygienist here is presenting the case to Dr. Karp. Now, she's out in the daycare center, and Dr. Karp's on the screen, 80 miles away, telling the history of the child. And Dr. Karp's here listening, and they do an exam, and they can actually get a really good look at the teeth and what's going on. And here's a tooth with severe decay. As you can see, there's a hole in that tooth. And really what Dr. Karp is also assessing is the behavior of the child to know what kind of sedation, whether, anesthesia or whatever may be needed because of the cooperativeness of the child as well as the severity of the decay. But they actually have quite fun over this. They're making faces at each other, and the children are very comfortable with it because they're in their own setting. So, did he make a face? I knew he was going to. So, all the children that we had referred there, they were within treatment within 2 months. It was really fabulous to see that happen. And then the other applications, National Center for Farmworker Health have done board trainings for us, cultural trainings. We're starting our 8 clinical works. It's just endless, really, what you can do. If we were to look at a SWOT analysis of the past year, I would say, and people on our panel and our administration, feel free to add to this. Our strengths are our vision, our passion, our positive attitude, our ability to manage change. Our weaknesses are, we don't have all the money in the world, so we are limited financially. Technology resources, you do, again, basically that's because of financial limitations. We're learning kind of as we go. And change is hard work. And opportunities are limitless, really, if we had time, money, and staff. And our threats would be, sometimes you'll hear providers say, oh, I just don't know if I can do this. Is it really... I really need to feel like I got to touch the person. I heard that a lot when I worked with the specialty care at the hospital system. The stamina to deal with change, fear of IT. I always tell my team I'm the worst IT person in the world, and just tell me what button to push. But I really can't figure out the IT stuff if you give me even a manual. So I think a lot of older people, especially, have that fear of IT. Payers still need to come along. They'll practice the mobility of the population, and of course the special needs of our farm workers. What does the future hold? Well, for us, we're looking at doing telepulmonary next. We have found a pulmonologist, and also looking at doing some occupational medicine consults for our farm workers. Home-based monitoring is a great field. People in the homes, there's been great studies done about this. Diabetics in their home, they can weigh themselves, take their blood pressure, take their blood glucose every single day. It gets stored in this little computer. The information gets sent to the medical home and reviewed by the care team, who can make almost immediate changes to that person's care, so therefore you have better outcomes. And also expanding teledentistry to other areas. And our healthcare control network, we were awarded a grant to work with the National Center for Farmworker Health and centers in Maine and Illinois to replicate telehealth. So we're trying to document the process we're doing, document curriculums to help other health centers do telemedicine. And we're focusing on diabetic retinopathy. We decided this morning was definitely our area we were going to try to replicate first. So, thank you very much. There is a resource list. Now,